Welcome to SheTV.com, where board-certified physicians talk to you about women's health. In this video, the doctors talk to you about hemorrhoids.
All right, good afternoon. I am Pooja Singhal. I'm a board-certified gastroenterologist with Oklahoma Gastro Health and Wellness in Oklahoma City, and I'm so excited to be here with my good friend, Dr. Jessica Enix, who is a board-certified surgeon, and we are thrilled to be talking about a very vulnerable yet very important topic, that is hemorrhoid health. So welcome, Dr. Enix.
Thank you. I'm so excited to be here. Like Dr. Singhal said, I'm Dr. Enix. I'm a board-certified general surgeon and work with Surgical Partners of Oklahoma. I take care of all sorts of different general surgical issues, but really understand the sensitivity that comes with pelvic health and hemorrhoid problems, and glad to be talking about it today.
Yeah, I recall one of the very first conversations, how we had gotten connected was I was looking for different surgeons and different referral sources for my patients for hemorrhoids, and we share a passion for anorectal health and prevention of anorectal health. And there's so many misconceptions regarding hemorrhoids that I think this is a very, very needed topic to talk about and discuss all we can do to prevent hemorrhoids, understand them better, and also discuss the treatment options and when to seek help. So having said that, Jessica, tell me a little bit about your experience with hemorrhoids. Like, when do patients get referred to you?
So I actually get referrals for multiple different reasons. I have had patients walk in before and be told that they needed to just simply come see me because their doctor examined them and saw this issue. And I've even had patients be referred because they thought they had hemorrhoids. They were told they had hemorrhoids. No one had ever examined them, and I was the first one to really tackle the issue. So I would say the most common complaint is usually related to bleeding with bowel movements or a sense of fullness, discomfort, and burning that really kind of gets in the way of daily activities.
Yeah, absolutely. I mean, just like yourself, I feel like I probably get a lot of referrals for hemorrhoids, for rectal bleeding, anemia, feeling a bump while wiping with the toilet paper, pain with passing stool, or just pain with sitting, and even itching around the anal area, which is very common. I also see a variety of demographic, and one thing that I think is important to address is hemorrhoids are very much present in men and women, and especially in women who are pregnant. And with that, let's talk a little bit about kind of the risk factors for hemorrhoids. I often tell my patients even a baby is born with hemorrhoids. So there's a common misconception that we don't want to talk about hemorrhoids because it's kind of like taboo. It's uncomfortable. It's sensitive to talk about. But the fact of the matter is that we are all born with hemorrhoid columns or cushions. And there's a different degree of swelling that happens in these hemorrhoid columns, leading to some of the symptoms.
Right, to symptoms.
Yeah. Do you also get that misconception when you're seeing patients?
Yes, most definitely I do. And this is something that has to be discussed because those hemorrhoid cushions, if I do operate on them or intervene on them, we do have to talk about the recovery period.
Absolutely.
And how their body changes while they're healing from that. And interestingly, Pooja, the thing is, even in the surgical field, not everyone agrees on that, but most colorectal surgeons will tell you that everyone walking around has at least grade 1 internal hemorrhoids.
Yes.
It's how our bodies can control when it's appropriate to have bowel movements, how we're able to tell we're going to pass gas instead of pass anything else.
Yeah.
So it is a vital part of how we control
Yes.
our bodily functions.
Absolutely, absolutely. And with that, I mean, I think it's also important. You mentioned grade 1. So for our listeners, talking about what does grade 1 mean?
So what grade 1 simply means, these are categorizing internal hemorrhoids. We have a grading system that mostly relates to the swelling size, how they prolapse, and if they reduce on their own. So a grade 1 internal hemorrhoid, like many other surgeons, I believe everyone walking around has these. It's swelling of the natural internal hemorrhoid cushions that help us with continence. Grade 2s are a little bit more swollen. They come out and they reduce completely on their own. Usually don't cause many symptoms, maybe bleeding. Grade 3 requires some assistance reducing them. And grade 4 oftentimes don't reduce at all.
Right. Right. So very simply put, if you're having to manually push in hemorrhoids, if you're feeling like there's pressure sensation when you're passing stool, and that pressure sensation, that leakage, you're trying to push it in, you're looking at least grade 3 or a higher level hemorrhoid. And that's what we call as prolapsing of hemorrhoids.
Correct.
And some of the risk factors, I'd like to take this moment to talk about what causes a hemorrhoid to go from grade 1 to grade 4. And some of the things I like to tell my patients are, squatting, lifting weights. So I have a lot of patients who are men who are doing, this incredible work for physical health in the gym, but then they'll come and they'll be like, I'm so healthy, I don't understand why I have hemorrhoids. Well, they've been spending way too much time squatting and lifting weights. So that's one of the risk factors that can lead to hemorrhoid swelling, prolapsing. So being careful and cognizant of that is very important. Pregnancy, like we mentioned, and the reason for pregnancy is the abdominal pressure. Compressing that veins leads to backup of blood flow, and swelling leads to swelling in that area. I also tell a lot of my patients who drive for a long time, truck drivers or people who just go on the weekends for 4 to 6 hours or drive, get away, and that's a risk factor. What are some of the risk factors that in addition to these, that you like to discuss with patients?
So I would say that's where my demographic starts to split.
Yeah.
Men, I would say I see more heavy lifting, and I never want to discourage anyone from doing physical exercise.
Yeah, absolutely.
But one can be extremely muscular and do it in the wrong way.
Absolutely.
And what I describe this as is uncontrolled heavy lifting that dumps through the pelvis, because we have a lot of strength in our buttocks and our thighs.
Yes.
And if we lose that core strength while we're trying to do squats or lift something heavy, the pressure comes through the bottom, and that becomes a symptom. The one that crosses over is by far constipation.
Yes.
Spending too much time on the toilet, and too much straining. And then something that I found that my women are actually very surprised about is pregnancy, even if they haven't had a vaginal delivery.
Yes.
So they're like, well, I didn't even
Sure.
I didn't even push the baby out.
Right.
But all of that change that goes on for the months ahead before the baby's here,
Yes.
leads to all of those symptoms.
Yeah, and I think these are the tips and tricks to really pay attention to for prevention. The right way to exercise or lift, avoiding heavy lifting, especially if you're starting to notice any hemorrhoids. And a great one that you mentioned that I deal with a lot is constipation. And I think it's very important to emphasize the treatment of constipation. So a lot of times when I have patients with hemorrhoids that are secondary to constipation or straining, I do love to talk about, let's address the basic problem first. Let's get your bowel regimen regular, and let's really talk about avoiding straining. And and we all in medicine really know this, but a lot of people don't realize how much time we spend on the toilet. People are on their phones or reading magazines, where really the rule is, and I really would like to emphasize this, is less than 3 to 5 minutes on the toilet. And using Squatty Potty is my favorite thing. And I know it's yours too, because you're chuckling. And it's, being scientists and being doctors, we really love evidence-based, and we really love things that are logical, and it just makes sense. Why does Squatty Potty make sense, Jessica?
So the reason Squatty Potty makes sense is because our anorectal canal is extremely complex. It is designed to have these shutter-type mechanisms that turn corners that, again, allow us to hold in what we can to be able to build up pressure and then to pass a bowel movement when we're ready. All of that relies on pressure, positioning, and angulation. So what the Squatty Potty simply does, it's a fantastic name. It's a little chair stool that sits right around the toilet. Simply pull it out, put your feet on it to have your legs leveled at a 90-degree angle. It straightens out that portion of the anorectal canal and makes it easier to pass a bowel movement without generating as much pressure.
Yes, so it really helps avoid straining. It opens up that sigmoid angle. So I always tell people human anatomy is such that we were always supposed to squat and pass stool. It's literally a built-in mechanism to store the stool, like you mentioned. So I think that's a very, very important part. And, one of the most satisfying things is when you have patients come back after using the stool or Squatty Potty, and they're like, yeah, that really made a big difference. Thank you for sharing that. And just to clarify, this podcast is not sponsored with that. You can use by the Squatty Potty. You can use a stool. The whole point is to lift up and mimic the action of squatting to open up that angle.
Yes.
So let's kind of delve into, we talked about what causes hemorrhoids and how we're naturally born with hemorrhoids. We talked about different types of hemorrhoids and symptoms of hemorrhoids, and also what are the risk factors. Let's now talk about some of the treatment options we have and how we approach it.
And what I would like to mention about treatment, a common question I get is, how bad are these hemorrhoids?
Yeah.
And I never describe hemorrhoids as bad based on what they physically look like.
Absolutely.
They are bad based on the symptoms that we are tackling to treat.
Right.
Obviously, we need to have a very good physical exam and make sure that there are no additional things going on. But hemorrhoids are not dangerous. They do not increase your risk of cancer. They do not create severe medical problems unless we're dealing with bleeding or something like that. So when it comes to interventions, we've already talked about some of the treatments for constipation, decreasing pressure, and oftentimes if that's the first complaint coming in, that's causing the flares, fixing the underlying problem keeps us from having to do surgery.
Yeah.
But surgery is always there. So surgery has multiple different applications. The thing that I always stress, though, is this is one of the most sensitive parts of the body, has hundreds of nerve endings. And you have got to be in a place where you want nothing more than to have your hemorrhoids fixed. The surgeries that I offer address either internal hemorrhoids only or internal and external. So when talking to patients about internal hemorrhoids, if they're experiencing more issues with the prolapsing, the bleeding, I examine them and notice that these are likely the symptoms. And it takes a nice long exam and interview to make sure that we're going after the correct symptoms. One of the really great approaches that I have had good results with has been a stapled internal hemorrhoidopexy.
Yes.
That allows me to remove all of the symptomatic internal hemorrhoid cushions without a risk of having something called anal stenosis. And it's a decently easier surgery to recover from in comparison to a traditional hemorrhoidectomy.
And we definitely want easy. And I think that's very important too, because it can be quite painful and you want your recovery to be as smooth as possible.
Correct. And something that I have to talk to my patients about is if we pick that route, then we will not be addressing any of the external hemorrhoids. However, we can get improvement in the way those hemorrhoids flare because all of that tissue communicates. If we address the internals, then we can decrease the amount of swelling of the externals, but the tissue does not get removed.
Right.
And it's that reason that it's easier to recover from than a traditional hemorrhoidectomy. Now, a traditional hemorrhoidectomy, I perform by actually cutting out the cushion that starts at the internal hemorrhoid, the blood supply, and then I take that all the way out to the outside to the external hemorrhoid. About 15 years ago, we stopped doing a surgery where we used to take all of the mucosal lining of the inside and including the outside external hemorrhoids. That led to a terrible complication called anal stenosis. And we would have to do things like dilate people's bottoms in follow-up clinic, which...
Well, thank God we're not doing that. Yes.
We no longer do that. However, when addressing the external hemorrhoids, we have to all agree that there is going to be pain. There's no way around it.
Yeah.
And that's the big thing that we have to talk about when picking the surgery that we want.
So how many days recovery for the traditional hemorrhoidectomy that involves both the external and internal hemorrhoid versus the stapled hemorrhoidopexy approach, which addresses the internal hemorrhoid?
So with the external and internal hemorrhoidectomy, if we're only addressing one column, I would say maybe 7 to 10 days. If we're doing more than one area, it is at least 2 weeks. And it really is the first 5 to 7 days that is absolutely miserable. But even that first 2 weeks, you don't really want to be outside home when you need to go to the bathroom. And then pain control is required to be approached from a multimodal standpoint, not just medicines, but also topical creams and warm baths and all kinds of things like that. And when it comes to addressing the internal hemorrhoids, that recovery period is more like 3 to 5 days.
Okay, much.
And then,
That sounds
you
much
know,
better.
by like 5 to 7 days, you're ready to get out of the house, and maybe we'll still have some discomfort and almost bruise type feeling with bowel movements for the next few weeks.
Well, fantastic. So that covers kind of the surgical treatment approach. And lastly, I would just like to add that there is the rubber band ligation approach that I can do in my office, and it takes about 5 minutes. And like we mentioned, there's internal and external hemorrhoids. And rubber band ligation is very good and only applicable to the internal hemorrhoids. And sometimes it really leads to, by treating the internal hemorrhoids, like you mentioned with the hemorrhoidopexy, similarly with band ligation, sometimes we can band the hemorrhoid columns and it will minimize and decrease the swelling of the external. And I've had really good results with the band ligation as well. So there are multiple treatment options for hemorrhoids, including topical ointment, band ligation, surgical option. But the key, I think we both agree on and strongly feel about, is addressing and minimizing the risk factors in treating the underlying problem. Well, thank you. Is there anything else you'd like to add?
Well, I think I would just like to add, anyone watching this that is going to see a physician, please advocate and be sure that you're able to talk about all the options.
Yes.
Because again, hemorrhoids should be treated when they're impacting your quality of life, but you should be given the multiple options because recovery spans from 1 to 2 days for rubber band ligation all the way up to 2 to 3 weeks with a
Very well
traditional hemorrhoid
said.
surgery.
Very well said. Absolutely. Well, thank
Great.
you.
Thank you so much.
Thank you for watching SheTV.com, where board-certified physicians talk to you about women's health. Please contact us at SheTV.com if you have comments or a particular subject you would like us to address.